Amber Roberts was 19 years old when she overdosed on heroin. Her father, Michael Roberts, had been planning to take her to addiction treatment on the day she passed away. He was just a little too late. Catherine Cleve was a college student whose mother described her as kind, smart, and hardworking. Her body was found on a concrete staircase in an empty concert venue after her repeated heroin use ended in an overdose. On average, 115 Americans die of a drug overdose every day. More than 630,000 US citizens suffered a fatal overdose between the years 1999 and 2016, with 63,000 of those deaths occurring in 2016 alone. The Center for Disease Control estimates a 14% increase in the death toll, around 72,000 deaths in 2017, equivalent to the entire population of New Braunfels. The current drug policy is to make the possession and use of harmful substances, including opioids, illegal. Ideally, the threat of punishment should be enough to prevent drug use. However, the rising death rates prove that it isn't. The nation needs a stopgap, a way to control the number of lives lost until a better solution can be found. As Catherine's mother, Kay Cleve, put it, "It's too late to save my daughter, but it's not too late to save other kids who will make stupid mistakes, as most of us have done." The first supervised injection facility opened in Bern, Switzerland in 1986. There are now over 90 facilities spread across 8 European countries, as well as 2 in Canada and 1 in Australia. Supervised injection facilities, or SIFs, also called drug consumption rooms and medically supervised injecting centers, were created to fulfill several purposes: reduce the number of overdose deaths, prevent the spread of blood-borne viruses, particularly the human immunodeficiency virus, or HIV, increase exposure to rehabilitation and therapy options for drug users, and serve the surrounding community by decreasing the number of used injection materials and public injection instances on the streets. SIFs accomplish this by providing the necessary materials for injection and allowing clients to inject themselves under medical supervision. It is important to note that while the facilities do allow drug use, which is generally agreed upon as immoral, it is with the intention of helping clients to ultimately end their drug use. Often, SIFs run jointly with or extensions of previously established homeless shelters and soup kitchens, allowing them to reach as many patients as possible. Supervised injection facilities would be a useful addition to the United States, but there are specific laws that stand in the way of their existence. The Controlled Substances Act under Title 21 prohibits the use of SIFs anywhere on American soil. Specifically, Section 844 allows the government to penalize anyone caught in possession of illicit drugs, including heroin, cocaine, and other opioids. Section 856 prevents the use of any private facility for drug injection and allows punishment of anyone aware of or involved with such facilities. While states can choose to go around the federal law, and sometimes do, as was the case with the legalization of marijuana in several states, they risk backlash from the federal government. The federal government should amend Sections 844 and 856 of the Controlled Substances Act to accommodate supervised injection facilities in the United States. SIFs should be allowed in the United States for 3 main reasons. Firstly, they increase the chances of recovery for illicit drug addicts by providing information on and referrals for resources ranging from drug rehabilitation centers to social welfare assistance. Secondly, SIFs benefit the overall community by decreasing the number of public injections and removing injection-related waste from the streets. Finally, SIFs are proven to save lives by preventing deaths caused by accidental overdose among their clients through the use of on-site medical staff. Supervised injection facilities should be established in the United States because they provide a better approach to treating drug addicts. An important job of the facilities is referring patients to outside resources like drug rehabilitation centers. SIFs are in a better position to make these referrals than doctors or other sources because the ability to inject drugs in a safe and supervised space draws users in. Studies done on established facilities often take into account the number of referrals made to patients, as was done with the 18-month trial report on the first medically supervised injecting center in Sydney, Australia. That center refers patients to 3 categories of resources: drug treatment facilities, healthcare consultations, and social welfare assistance. In the first few months, MSIC workers made a total of 1,385 referrals to about 15% of all clientele. Written referrals, which made up about half of the total referrals, were used to determine how often patients visited the referred agencies. The study found that 20% of occasions in which a written referral was provided resulted in subsequent attendance of the patient to the referred agency. Of the 197 clients who were referred to centers specifically for drug treatment, 39 people followed up with the recommended treatment facilities. While this number may not be mind-blowingly large, it still represents 39 people who found treatment within just 18 months of the center opening and who may not have entered treatment otherwise. The hope of the Australian facility is that those 39 people would turn into 300 and then 3,000 people, all on the path to recovery. While there are clients who may take advantage of the ability to inject drugs without legal consequences and who may have no intention of entering treatment initially, the study found that users who came to the facility more often were more likely to go to outside resources. Patients who made more than 10 visits to the MSIC were 18 times more likely to visit one of the referred agencies than patients who visited less. Not only was the MSIC taking advantage of the ability to refer patients, but a good portion of the referred patients were actually following up with the recommended facility and getting much-needed treatment. Similar results appeared in studies done on the first supervised injection facility in North America. Statistics taken by Insight, located in Vancouver, Canada, documented over 10,000 referrals to outside resources in the years 2015 and 2016 combined. Several studies show how many of these referrals from Insight were utilized by patients. One study, based on the responses of patients who had visited Insight, found that 57% of surveyed patients entered or attempted to enter an addiction treatment program after visiting the facility. A second study found that a 30% increase in the use of detoxification treatment, the process of quitting drugs and experiencing withdrawals, accompanied the opening of Insight. The goal is to get all addicts into treatment. And though that goal clearly hasn't been reached in Sydney or Vancouver, the current numbers are a promising start for both. SIFs are just stepping stones toward addiction treatment, but without them, many people may never get the help that they need. Supervised injection facilities should be allowed in the United States because they benefit the overall community by cleaning up used injection materials from the streets and reducing the number of public injections made by drug users. Removing used syringes from public areas lowers the potential for accidental punctures and the spread of infectious diseases, while reducing public injections lowers fear and social rejection of certain areas. All this to say that by achieving these particular goals, the facilities become useful not only to drug users, but also to other members in the community who may have no other connection to them. Many of the European SIFs aim to aid communities in this way, and their reports often record data related to the effects on the surrounding area. One study done on 5 districts in Barcelona recorded the number of used syringes picked up off the streets in the months before and after drug consumption rooms were introduced. The first room opened in 2004, with an average of 13.1 used syringes found on the streets per month. Another room opened in the following years, and the monthly average of collected syringes continued to drop until the end of the report's timeframe in 2012. That year, the average was 3.1 syringes collected per month, a 75.6% decrease from 2004. The drug consumption rooms were effectively able to remove used syringes from public areas, lowering the risk of accidental punctures and ultimately making the districts cleaner and safer for residents. Another product of the facilities that benefits the overall community is a reduction in the number of public drug use incidents. Mother Rebecca Beatty and her 4-year-old son witnessed firsthand a homeless man attempt to inject himself with illicit drugs in the neighboring booth of a Subway restaurant in Saskatoon, Canada. Quote, "He pulled out all the supplies to shoot up intravenous drugs. Instantly, my heart kind of fell," end quote, Beatty said of the experience. She went on to assert that if a location specifically for drug users was set up in Saskatoon, the event in the subway probably wouldn't have happened. Her assumption isn't wrong. Data from client surveys taken in Biel, Switzerland and Geneva, Switzerland compared the most common locations of drug injection in 2000 and again in 2002 after a facility had been established in each city. In 2000, 21% and 18% of users in Biel and Geneva, respectively, were more likely to inject drugs in public places. When Beale users were interviewed again in 2002, only 1 of the 49 interviewees reported mainly injecting in public, while 49% reported using the local SIF most often in the previous 6 months. Similarly, only 10% of Geneva users most frequently injected in public locations, with 29% injecting most often at the established facility. In both cities, the percentage of injections occurring in public dropped. This means more users turning to SIFs, which can again lead them to treatment, and a lower likelihood of experiences like Miss Beatty's. The presence of SIFs can help all members of a community, including the ones who may never step foot in a facility. Measures should be taken to allow the establishment of supervised injection facilities in the United States because SIFs effectively prevent overdose-caused deaths. SIFs are typically equipped with teams of medical staff ranging from physicians to general nurses on site during all open hours. While not permitted to physically help clients inject drugs, medical personnel are trained to see signs of an overdose and respond accordingly. Furthermore, many locations keep naloxone hydrochloride on hand for overdoses with a great potential for fatality. Naloxone hydrochloride is an opioid antagonist that can be injected in emergency situations involving heroin, morphine, and other opioids. It reverses or inhibits the symptoms of opioids, including respiratory depression, which is often the most deadly symptom. These methods allow SIFs to reverse the effects of an overdose before it results in death. Data from several different facilities running across the world support the claim that SIFs save lives by preventing overdose-caused deaths. A study done on Insight in Vancouver compared the number of potentially fatal overdoses that occurred in the facility to the number of overdose-caused deaths in the surrounding area between the years 2004 and 2008. Factors such as the use of naloxone and the need for an ambulance were used to determine whether or not overdoses would have been fatal had they occurred outside of Insight. A total of 1,004 overdose incidents were managed by the facility during the designated time period, and 453 of those events were determined to be potentially fatal. While this may seem like a high amount of overdoses, the number is consistent with overdose data from Vancouver before the facility opened. The study estimated that Insight had prevented a range of 8 to 51 deaths during that time period, an average of 2 to 12 deaths per year. Put in simpler terms, a minimum of 8 people would have died had they suffered overdoses outside of Insight during the studied years. This is at least 6% of the total overdose mortality burden on the surrounding neighborhood. While the magnitude may not be as great as one would imagine, the study still serves to show that SIFs are successful in saving lives among drug users. The MSIC in Sydney, Australia produced comparable results. The MSIC managed 329 overdoses in the first few months, 81 of which required the use of naloxone. Using factors from other overdose scenarios in the surrounding community, the study estimated that around 13 overdose-caused deaths had been prevented by the MSIC in the first 18 months, between 4 and 9 deaths per year. This number lines up with Insight's estimate of between 2 and 12 lives saved per year. Additionally, as of 2015, the Sydney MSIC had managed 5,925 overdoses with no fatalities. Ideally, clients of the MSIC wouldn't be overdosing in the first place, but the medical personnel have been proven to be invaluable, and clients who overdose are strongly encouraged to enter treatment to prevent future overdoses. A report comprised of data from all 19 of Germany's facilities found further support for the argument that SIFs effectively prevent overdose-caused deaths. In the years 1995 to 2001, the German facilities managed a total of 2.1 million injection incidents with no resulting fatalities. Furthermore, the study classified 5,426 of the cases as potentially fatal had immediate emergency services not been provided, and overdose deaths documented by police reports show a 9.6% decrease in overdose-caused deaths from 2000 to 2001. The same report also compared drug death rates from 4 specific cities, Saarbrücken, Hanover, Hamburg, and Frankfurt, to determine the actual effect of the facilities on overdose-caused deaths. In Hamburg, the number of drug-related deaths dropped from 184 in 1991, before the establishment of a facility, to 101 in 2001, after a facility opened. Similarly, drug-related deaths in Frankfurt decreased from 147 in 1991 to 36 in 2001. The German report used a time series analysis model, which showed that a statistically significant effect on the number of overdoses was achieved approximately 6 months after the opening of each facility. Drug death rates from before and after the introduction of facilities into communities show that SIFs fulfill the goal of preventing overdose-caused deaths. To put it simply, SIFs are proven to save lives. One common concern is that the facilities will bring crime to the neighborhood. This theory is discredited by the results of the 18-month trial report on the Sydney MSIC, which accounted for theft, robbery, and drug-related loitering. The study found that there was a steady increase in crime leading up to the opening of the MSIC and a gradual decrease in crime in the months after the facility opened. While the decrease in crime can't necessarily be attributed to the establishment of the facility, it still shows that there was no great spike in criminal behavior. Logically, if clients are bringing in their own illicit drugs, they are likely funding some sort of illegal drug ring, as they are clearly buying drugs from somewhere. However, this criminal activity doesn't seem to directly affect the surrounding areas of the facilities as some people think it may. Another big argument against supervised injection facilities is the matter of how to pay for them. Many law-abiding, tax-paying citizens find issue with the idea of their tax dollars allowing someone else to break the law and use illicit drugs. This is a reasonable concern. However, in the long run, these facilities will actually save the country money, as is the case with the Vancouver facility. A study simulated the conditions of insight and determined the overall net savings of the country within 10 years based on 3 benefits provided by the facility: decreased needle sharing, increased use of safe injecting procedures, and increased referral to treatment. With these effects combined, the study estimates a net savings of over $18 million. A similar study took data from existing locations and applied it to Baltimore, Maryland, a city of about 614,000 people. They predict that if an SIF costing $1.8 million annually was set up in Baltimore, it would generate $7.8 million in savings, prevent 6 overdose-caused deaths and 108 overdose-related ambulance calls, and bring an additional 120 patients into treatment. These would be the results of one facility in a single American city. The potential power of the facilities to save lives and money across the nation is incredible. Supervised injection facilities are a much-needed stopgap for the United States, and amending the Controlled Substances Act is a necessary step toward establishing them. The rising number of overdose fatalities every year shows that the current drug policy isn't working. SIFs are capable of benefiting both addicts and their communities, and while the methods may be unconventional and perhaps disagreeable, the data proves that the facilities are working. I'm sure we could all agree that drug use should not be supported in the best of times, but these aren't the best of times, and too many people are dying for us to pretend otherwise. The over 500,000 deaths I described earlier may seem horrific, but distant. However, for people living in big cities like Seattle, San Francisco, and New York, those lost lives are all too real. Amber Roberts and Catherine Cleve left behind heartbroken families and friends. They were drug users who made mistakes, but they were also just young girls caught up in the dangerous habits of a struggling generation. It may be too late for them, but it's not too late to make a difference in the lives of the thousands of others making those same mistakes. And this is how. Thank you.
All right, for those of you who just arrived, let me read off our judge intros for you. So on the panel tonight, we have Nathan Aliquin. Since writing and presenting his senior thesis on education and standardized testing, Nathan went on to receive 2 bachelor's degrees and a master's of science in instructional design and evaluation. He currently works as the instructional designer for Google's Cloud Technical Residency Program at their office right here in Austin. We also have Susan Sprouse, who's been a parent at Veritas for 10 years now. Currently, she works as an estate planning and probate attorney with the Sprouse Law Firm. Disclaimer, Susan's questions and comments this evening may or may not reflect her true opinions and beliefs. We also have Jimmy Miller, who has a BS in Communications from the University of Texas and a master's in church history from Gordon Conwell Theological Seminary. James is passionate about organizing historical research in new forms and reinserting theology as a core component in historical discussion. He currently works to create and refine corporate learning and onboarding pedagogy. His favorite episode of Classical Stuff You Should Know is Everyone's a Critic. We also have Jordan Vermont. Jordan currently serves as the chair of Veritas School Board. He is married to Bianca and they have 5 children, all enrolled at Veritas. Jordan is a partner and litigator with the law firm of Reed, Collins & Sy, LLP. As a practicing attorney, Jordan represents clients nationally and internationally in complex business litigation. All right, you guys know the drill with paddles, so the floor is open. Go ahead.
Had to be quick to beat Nathan. Okay, so congratulations to you on picking a topic that's so controversial, and well done. So here we go. Practically, I'm just curious how this would work, because if I were, say, a police officer in a town that had one of these facilities, I would camp out across the street and watch people. So where's the line where it would not be illegal to own heroin, right? Like if they're in 20 feet of it, because they're bringing their own drugs, correct?
Yes.
Okay, so the officer is watching. Here go these people in and out of this place. I'm thinking they would bust them immediately. And if the people know that's what's happening, they're not going to be affected. Those places will not be effective. So what's your solution for that issue?
It really depends on the opinion of the police officers of the police department as a whole and whether or not they're supportive of it. In all the facilities that I looked at, the police department seemed to be supportive of it. I read an article on the facility in Insight in Vancouver, and they it basically looked into that, what the ideas of the police department was. And in that case, at least, they recognized the goal of the facility. And in one situation, especially when the facility first opened, clients who were trying to go into the facility were being harassed by neighbors, people who were in opposition to the facilities, and police officers were actually trying to get those people into the facilities because they knew that the goal isn't for those people to break the law and to get around the law and to use drugs continually. The goal is to get those people into treatment and save their lives. It depends for sure on whether or not the police department is supportive of it, but generally in the cases I've seen, the police departments have been supportive.
Nathan.
So actually, to follow up on that, that's a really interesting point because you've brought up some really interesting case studies with ample evidence of other countries implementing these SIFs and how those tended to work. I'm curious because I'll do another anecdote and we'll see if this helps illustrate my point. Somebody who plans exclusively on using drugs outside of SIFs in possession of those illegal drugs are then caught possessing those drugs, even if they're 2, 5, 30 miles away from an SIF. It would seem reasonable for them to then defend themselves by saying, no, I only use these drugs at the SIF. So in these other case studies that you've been looking at, are there charges for mere possession of these illicit drugs? And if so, it's really just a similar question, but I guess in a different application. How do the police officers make a determination as to whether or not it's reasonable to arrest somebody for possession of those drugs when anybody can use the SIF as an excuse?
Yeah, all the studies that I looked into, none of them really looked into arrests or court cases. I did find a little bit of information on the effects on the surrounding community, and so part of that included like drug-related loitering, and I mentioned that in my thesis. And that was really the only thing related to kind of arrests or criminal behavior that I found. Most of them focused on what was actually happening in the facilities. I imagine that the idea of these isn't to restrict police behavior or police their basically territory, what they are and aren't allowed to do. And I imagine in that case, the police would be, they would be allowed to arrest people depending on, based on their personal opinions.
So in these other situations, the police have discretion to determine whether they can arrest somebody for possession based on their perception of how likely they are to use SIFs? Is that what they're doing elsewhere?
Yes. And again, I didn't find a lot of information on that in the actual reports. The only thing I found was the relation to criminal behavior. But the way that I understand it, I believe that would be the case.
Mr. Miller.
I'd like to expand on the first question, just the scope of it. So in looking at your studies, it would seem that by creating these places within communities, it's not just the police that would know who were going to these SIFs, but the community at large. And so you did cite the statistic that people who went and injected were 18 times more likely to go into rehab. But I would like to know, are there any studies that show the ability for people who enter treatment after going to these SIFs, how easily are they able to reintegrate into their communities, or do they find themselves ostracized to the point where they return back to using?
It's a little bit difficult to trace the path of clients through treatment because of patient confidentiality. A lot of the studies and the reports that I looked into, they can't give specific client cases or people who followed all the way through treatment just because of patient confidentiality rules. I found 2 more cases of people with specific testimonies who went into treatment and then actually came back out into the facility or came back out into the community, and they were, successfully able to reintegrate. One woman, her name was Shelly Tomick, and she had been a drug user since very, very young. And she actually started working on the streets as a prostitute to pay for her drug addiction, and she got pregnant with her first child at 13 years old. And she continued to use drugs until the Insight opened in Canada, and she started going to that facility. And she didn't get into treatment initially. She kind of continued to use the facility while it was there. And then actually in 2011, when they were basically the Canadian Prime Minister was trying to shut the facility down, they asked her to join in the campaigning to keep Insight open, and she did. And that was when she really became clean. She stopped using, and when at the time that she was interviewed, she had been clean ever since that point. And she actually, after getting clean, she continued to work with Insight to try to keep it open. But she also went back to school. She was working when they interviewed her, and she basically had put her life on a completely different path. And it seemed to work for her, and she mentioned that some of her friends saw that in her, saw her transformation, and followed her.
Mr. Vermont.
Excellent presentation, very compelling. It seems like the permitting these SIFs is going to, on some level, reduce some of the stigma associated with drug use. It would probably also reduce some of the reluctance to try hard drugs in particular, because you would have less incidences of, getting some sort of disease or using a dirty needle. So what would prevent these SISs from having the effect of actually encouraging first-time users? Maybe someone bringing a friend along, the friend's reluctant, but the current user says, hey, don't worry, it's clean, it's safe, you'll be protected. And wouldn't that end up having long-term effects of increasing drug use and potentially increasing overdoses?
Yeah, that's a great question. I looked into that a little bit just because I was concerned initially about, first of all, age, like the qualifications, who can come into these facilities, who can use drugs, who's actually allowed to. And they do, most of them have specific qualifications. So you have to be at a certain age. You have to be, some places it's 15, some places it's 18. I think Insight it's 19. And then also they don't really serve first-time users. Generally, when you come in, the way that it works is you fill out basically a kind of a client profile, and you give your information, and then they know who you are every time you come in, and that's how they trace how many times people come in, and that's where they get a lot of their data from. And the majority of the people that come in have been addicted for many, many years. There really are very few cases where they actually allow first-time users to use the facilities. And even if they do, they have like a specific set of procedures for those people. So it tends to discourage first-time use.
But they do allow first-time users.
I think so. From what I saw, most of the cases were people who had come in and had been addicted for years and years and years. I think there were very, very limited cases in which first-time users actually came in. They tend to push those people away.
But wouldn't that data be relying on a drug user to tell the truth?
Yeah, you're right. And I looked into that too also. In the scientific field, it's generally understood that drug users tend to be more honest about their behavior. If anything, more just because they don't really have a reason to. If someone knows they're a drug user, they don't have any kind of saving grace. They're not trying to save their personality. And they're generally, in the scientific field, from what I understand, it's generally accepted that drug users are more honest than usual about their behaviors, and that's why a lot of these studies work, and that's why a lot of these studies were used as methods to look at the facilities and weigh the pros and cons, because it's generally accepted that they are more honest.
So one more, and then I'll move on. So, but if that logic holds true, then wouldn't these first-time non-drug users be more likely to lie, in fact, that they are drug users?
They could absolutely get under the radar, and there's no really way to track that. And so you're right, that could be a possibility. And my recommendation for that is if we were to implement these in the United States and we were to see more first-time drug users, we were to see an increase in drug use, we would say, look, this isn't working, we need to try something else, or we need to cut these out. The idea of these is just to put them in somewhere and see if they work, see if we can get the results that we want, and if we don't, we take them away. They're not a permanent solution at all.
Okay, so this feels really Brave New World to me, which I think is a book that y'all are required to read at Veritas, where all of the citizens, the government encourages the citizens to take Soma, which is a drug that calms everybody down, and it's socially acceptable, and people just know that's what you do. So I would worry about this, that over decades, you know, it would be like a Starbucks. You know, we have this facility on every corner, and if you're stressed out, that's where you go, and nobody thinks a thing about it, right? That we would just become dull, or, you know, to that issue, that it's not really a problem. It's just something that everybody does. How would you respond to that?
Yeah, I would say that at least the way that I look at these, they aren't a way for drug users. They aren't a way to make drug use easier. The important thing to focus on for these is that, one, the goal is to just stop people from dying from overdoses. That's really the key thing here. And then also the important goal is that we're trying to get people into treatment. We're not trying to make it easier for them to use drugs or to feed their addiction. We're trying to get more and more people into treatment. And part of that includes adding other programs to this. This isn't the only solution per se. I think it's a needed one, but there are other ways, other things that we can add in, whether it's diversifying treatment programs or adding other things in to make sure that we're getting the results we want, which isn't to make drug use easier, but is to get more people into treatment.
Follow up.
I'm pulling a
You
Jordan.
almost lost it there, but you got it up in time.
Okay, so you just said part of the goal was to make sure that people aren't overdosing. In your answer, but I think, what if people know that they're going to be somewhere where there's doctors right there? Don't you think that increases the chance, like, I'm going to up my dose, right? So all those statistics that you gave, like, if they wouldn't have been there, then this many people would have overdosed. Like, how do we know that's really true, right?
Yeah, you were not the first person to ask me that. From what I looked into and what I found, there was actually one report that I looked at. It was a study done by the University of Columbia, and they found that there basically wasn't an increase in high-risk behaviors in the patients. Patients weren't actually upping their doses the way that people thought they may. And the logic that I kind of used to understand that is that, one, it's expensive. If you're using more than you actually need to feed your addiction, to give your body what it needs, you're basically throwing away money. And a lot of these addicts don't actually have that money. They don't have the money to feed an increased intensity of drug use. They really are only trying to take in as much as their body says they need to, and they're not trying to add this much more to get this much more of a high, a lot of times just because they can't afford it.
Mr. Miller.
So I am ignorant with regard to international countries, their zoning laws and eminent domain. And so you mentioned earlier that these centers were not associated with a rise in crime, but rather a decrease in crime. Before that information was known, how did these countries, how did Germany, how did Australia, how did Canada create space for these locations within their communities?
Like, where did they put them?
Yeah, how did they decide where they went and who made that decision?
Generally places where they would be able to reach the most patients. So an example is in Philadelphia right now, they're actually trying to open a facility. A nonprofit called Safe House is in the process of trying to get one open. And they actually, I'm not going to remember who it was, but someone basically sold a building to them for $1 because they wanted the facility to be in that place. And the place where they want the facility to be is basically on these cross streets. It's in Kensington, which is in Philadelphia. And that is a place where there are known addicts hanging out. They find people on the streets all the time who have overdosed. All the residents there see, I've read horror stories of people who live there, and There was a man who had a tattoo shop there, and he mentioned that he pulled a girl out of a toilet because she overdosed and her head fell in the toilet. And, you know, he saw people like that on the streets. And so that would be a place where they believe that would be the best place for the facility to go because they could reach as many people as possible.
Just to follow up, so I guess I was curious as to say, in Germany, did the German government say, no, this building is going here? I know in America, this would be a communal issue, but in Germany or in Canada, did they just unilaterally make the decision that this center goes here?
From the way I understand it, generally it's the government that says this is the best place to put it or this is the best place to put it. And there have been instances that in the US, like I said, governments have been trying to get the facilities put in place and no one has yet. But they're trying to pick locations and there have been some backlash from the people, but usually it's the government that says this is where we want to put it, this is where we think it'll be best. And I think there was another case in Washington where the residents actually built a petition because they didn't really want it in their neighborhood, but the government decided that would be the best place for it to go.
One more, are there any instances where the community was vehemently against a center being placed there and losing because the government decided, no, it's going here anyway?
Not that I know of. I know that there has been backlash from some of the community members, but in general, it's split half and half, or you know, there's some people that are for and some people that are against. And yeah, there hasn't been any situation that I can think of where everyone in the community has said, no, we don't want it here, and the government said, well, we're doing it anyway.
All right, Mr. Eloquent, you've been waiting, so patient.
So you only spoke at the very beginning of your presentation about the specific action that you would like to take, which is to repeal 2 particular sections of the Controlled Substance and Abuse Act. And I guess what I want to understand is there are all these wonderful case studies of other countries implementing these SIFs and the data and results of those. What are the major roadblocks keeping the United States from unilaterally implementing SIFs here?
Yeah, just a small correction. I don't want to repeal sections 844 and 856. I just want to amend them. Basically, the way that I imagine it would work is they would provide an exemption almost for the facilities. They would say that still is applicable everywhere else in the country except for in this facility. In this facility, it isn't the case. And the biggest thing standing in the way right now is the government. The federal government generally is pretty strongly against it, and maybe it's just because of who is in which position right now, but the Justice Department is the one that they actually sued the nonprofit Safe House who's trying to open a facility, and that court case started in February. So it's the state governments that want the facilities to be put in. There's multiple states, California, Washington, Pennsylvania, all of them. They want to put these facilities in their states, and the federal government has been pretty adamant about it not happening.
Ms. Vermont.
As I understand your proposal, the goal is to increase treatment for these drug users and to reduce the negative outcomes from not seeking treatment. One of the things you noted in your presentation is that it would reduce the public use of using heroin. And as distasteful as that is, doesn't public use mean it's more likely for them to be arrested for that illegal use, number one? And then number two, wouldn't that then provide the opportunity for law enforcement to force treatment on people that are using? So couldn't we actually achieve your outcome by just forcing them into the public and then actually enforcing our criminal laws so that they would not just be detained, but actually go through a treatment to get them off their addiction?
Mm-hmm. One of the other ways that I looked into that we could help kind of slow the spread of addiction and encourage patients into treatment is streamlining the process for detoxification in jails right now, because ideally that would work. Ideally that would be the case, is they would arrest people for using drugs or having drugs, and then people would go to the jails and then they would go through detoxification and it would work. But generally right now that isn't the case. So I looked a lot into the statistics surrounding jail treatment, and I found that basically like 65% of, this is from the Columbia University, around 65% of inmates need treatment and only around 11% of them get treated, because I want to say I think it's 2/3 of jails don't actually have treatment programs in place. There are some that have great treatment programs in place. I think Rikers Island in New York, they have this KEEP program that has worked really, really well, but they are the exception. They aren't the rule. Most jails don't have good programs set in place, and the risk with that is when you bring in an addict who's far along in addiction and then you put them in a jail cell and you basically just let them go through the withdrawals, they can have really bad symptoms. So there was an example of a man in a jail cell who they put him in, they didn't give him any type of treatment, any type of way to cope with withdrawals, and he had a heart attack. And under a different situation, in a different situation, he could have died. So that's the danger of just forcing them into withdrawal, is it doesn't always benefit them, and also a lot of the jails don't actually have treatment programs set up.
We only have 30 seconds left. Is either of these real quick? Real quick?
I can make it real quick.
You promise? Okay.
Yeah, well, maybe. Okay, so, we have a lot of people in the world that suffer from alcoholism, but we don't provide alcohol to those people. We provide therapy. So in some way, this feels like kind of giving up. How would you respond to that?
I would say, again, the idea isn't that we don't want to give up. We don't want to just say, look, you can use drugs and we're just going to keep you alive so you can use drugs. The goal really is to get these people into treatment, to encourage them, first of all, to say, look, I see you in your addiction and I want to walk with you and I want to be with you in that process and I want to see you get into treatment. And I think that's a big difference from the way that the culture is now. We look at drug addicts and we kind of push them away and we say they get what they deserve. If they overdose, that's their fault for using drugs. And that's not saving anyone. That's not putting people into treatment. That's not saving lives. And so this is just a different way to approach it and a way to hopefully save more lives and get more people into treatment.
All right, that is it. Thank you.